Hi, Michelle.
Hi, Jeff.
We're turning the spotlight on an exciting new resource, PharmacyBridge.org. If you're interested in how pharmacists can play a more central role in treating opioid use disorder, or OUD, we'll unpack that in the next 30 minutes. Fewer than 1 in 5 people with opioid use disorder in the United States receive life-saving medication for their disorder, yet 90% of Americans live within 5 minutes of a community pharmacy, a massive, untapped opportunity for pharmacy practice and the patients the pharmacists serve. The PharmacyBridge website seeks to harness that opportunity, so we'll dive in. So hello, pharmacists and friends. Today's Friday, October 24th, 2025. Welcome to The Regimen in collaboration with Drug Topics, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues and solutions. Listen to find out how we can all improve population health, health equity, and patient care through education and advocacy. And we're doing all of those things promoting a website here. I'm Jeff Bradford. I'm a clinical professor of pharmacy practice and clinical research at the University of Rhode Island College of Pharmacy. As a reminder to our listeners, the opinions expressed in this podcast by the hosts do not represent the opinions of the United States government, the University of Rhode Island, the Legislative Analysis and Public Policy Association, or LAPA, nor the Foundation for Opioid Response Efforts, or FOR. So I'm thrilled here to welcome my friend and colleague and co-host, Dr. Michelle Catano. Michelle is the guru behind PharmacyBridge.org. It's funded by FOR, with data provided by subcontract to LAPA. So welcome, Michelle, your first time on the pod.
Thank you so much. I'm so happy to be here.
I emailed you a couple weeks ago and I said, we need to advertise this. And if you're watching this on YouTube, that's also the content derivation here. So we're on all the channels and all the socials, and hopefully we'll have lots of things here. Michelle, tell me how you got wrapped up into this project.
Well, I am fortunate enough to be a grant coordinator here at the College of Pharmacy, and you were able to help to bring me in to this grant that has been supported by FOR and work to move this project forward because it's been a long time coming.
Absolutely. We worked with a web designer, Hulafish, which also works with the college, and they were fantastic in getting this moving, and we are live and continuing to update this website. So you've mentioned FOR. I got a grant a couple years ago from FOR with 3 aims. One of those was creating a policy document. And the full document, it's 434 pages, I think.
Quite extensive.
And so we said, about a year ago, we said, okay, so this report's coming. Is anyone going to read it? It's divided by state. How do we get this out to people? It's kind of like, as academics, we publish papers, and if nobody reads them, change doesn't happen. So how do we get change to happen when we have 80% of people not getting access to these life-saving medications? OUD is a major public health crisis. Medications for opioid use disorder, or MOUD, particularly buprenorphine, which is one of 2 available in pharmacies. They are evidence-based, they reduce risk, they reduce death, all-cause mortality. They're fantastic, but we don't have access. And part of that access is limited by policy. Part of it's by limited access to best practices. Where is this happening? So we said, let's have a website that does all of those things, because pharmacists are underutilized. They're in their communities. So we have regulatory, legal, and operational barriers. So we're trying to overcome all of those things. So we said, let's map these barriers. We had a report, and let's make that report as a living document. So let's talk about what the website is here. First, when I showed this to everybody, they love the website. Thank you, Michelle.
Thank you. I'm so glad that they enjoy it.
Tell me what was your inspiration for the design and the logo and things like that.
Well, as far as the colors go, I was inspired by URI, honestly.
There we go, Rhodey
These
blue.
are some Rhodey blue colors, as well as the, orange that goes with it to sort of make it pop.
Mm-hmm.
And so really, I wanted to drive home that point that, these are life-saving medications, and people could have access to it if only we had the legal framework to make that happen. Pharmacists can help bridge this gap and make these more widely accessible and save a lot of lives that way.
Absolutely, and there's lots of other bridge programs that happen to be sponsored by FOR, and we have links to all those groups. And so, again, my thought for the website is to link all these things, because I get emails saying, how do we do this? I think a lot of what we do in academia is create a lot of things for each other, and we're still siloed. So that's why we're sort of doing this push. So let's break it down. So the key point that we've been talking about is the legal landscape. You created some national maps.
Yes. So thanks to LAPA's extensive investigation, we have a gigantic spreadsheet that tells us about the various laws in all of the 50 U.S. states and the District of Columbia and Puerto Rico. And with that, we were able to create what are called or known as hex maps.
And why did we want hex maps, Michelle?
Well, we specifically chose hex maps because here in Rhode Island, we have a little bit of a Napoleon complex. And we are the tiniest state. And every time you see a normal geographical map, it's very hard to find us, or sometimes we don't even exist on the map.
Yeah, maybe we're out in the ocean. They're like,
exactly.
RI, how do we code you?
They point to us. Sometimes you can't even click on it because it's so dang small.
I know.
So in order to equalize the size of all the states, we chose hex maps.
From our friends at Data Wrapper. So
Yes. We were inspired by an NPR article that you read and found out that we could make those same maps using Data Wrapper. So we used that in order to make the space distribution equal among all the states.
And really it's because it's about policy. While, the policy is in a large either geographical state where, again, pharmacists are closing the gap in rural areas, so that's important geographically. And then large population states, we want to see those things. But that's all information everybody knows. I think what we want to know is, like, who are the states around you? Can you contact them? And then, Rhode Island is a leader in policy change. I've been lucky enough to work over the last 10 plus years to create laws here that other states adopt and be featured in national groups like the National Governors Association and other conferences and things. But yeah, when you look at a map and you go, where's Rhode Island? Where are we? What's happening there? So the hex maps do it, and again, I think folks really like that. And then the hex maps, you hover over them, you go to a state, and tell us about the state pages.
So each hex connects to a state. Every state or jurisdiction has their own page that contains 3 sections. One is really just a copy and paste from the LAPA report, right? Because, again, I think it's unlikely that most people are going to go digging into a 434-page report. And so in order to make this readily accessible so people could just get in and see what their state has, you can just click on that state's page. And the first thing you're going to see is a list of the questions, the 10 questions that we were sort of focused on in this report, and then the answer to those questions for that state.
And so we're trying not to overwhelm folks even on the page. One great thing is this is mobile enabled. So if you're listening to this and you're driving, don't go on the web like I would do. Very bad public health moment. But it's Rhode Island, nobody notices. I'm usually stuck in traffic all day. But you can go to it and you can, look at all the questions. We worked with LAPA and my team, Heather and Nathan. Shout out to our consultants who are fantastic help to this report. The 10 questions weren't really like, can pharmacists prescribe buprenorphine? We do ask that question, but we realized there's lots of ways the pharmacists can do it. So we broke it down by, can they prescribe buprenorphine independently, which is our goal. I think that's a whole other podcast on independent prescribing and a paper coming out from this report. And then there's, can they prescribe by collaborative practice agreement, because that's being done. We did that here in Rhode Island, which inspired the grant and inspired the website. And then we thought, well, we need to know more about, not just whether you can do it, it's how broadly can you do it. So this is the first report and the first website. You'll go to national pharmacy organizations and find similar kinds of maps on pharmacist authority, but not directly towards buprenorphine nor controlled substances. So it's really specific, but I think there's a broader impact here. So it's prescribing. It's administration, so we just presented some of that research there. Can you administer buprenorphine? Because long-acting formulations are really groundbreaking, and recent data has supported initiating with long-acting medications. So there's another aspect of pharmacy practice.
And better retention too, right?
And better, yeah, exactly. Better retention if you start off with injectable in one recent study. So it's really interesting to think that people could walk into our pharmacies and leave with buprenorphine strips or pills. Now, if you have the authority or you're pushing for that authority to walk in, get that injection, and they're good for the month in terms of not dying. That's really amazing. We do things like long-acting antipsychotics and other things. we want pharmacists to think about, and organizations and employers to say, this is really an opportunity that I think remains untapped. What are some of the other questions, Michelle?
So we have, like you said, administration, but also coverage.
Yeah.
Insurance coverage.
Scope is great, but if you're not getting paid.
Exactly. At the end of the day, if nobody gets paid, this isn't going to happen, right? So it sort of started with Medicaid. That was the initial focus, obviously, because that does vary from state to state. But as a result of having to figure out what Medicaid does not cover in a state, they also, wound up sort of figuring out what the laws were regarding commercial insurance plans as well.
Absolutely.
Whether or not the laws in a state, allowed for or required commercial insurers to cover pharmacist services. And so obviously, again, that varies very much by state.
Yeah.
But there are many states where some pharmacist services are covered, perhaps not pharmacy-based buprenorphine.
Exactly.
But
or it hasn't been explored.
Right, or it hasn't been explored. But at least if some commercial insurances are covering some things, it would be an easier lift in your state to potentially get coverage.
And that's where we get to credentialing and all these things. Again, we're just sort of, the policy is meant to say, what can you do? And then advocates and students and faculty and associations and policymakers should say, wow, this is a way to do this. Medicaid, actually, coverage is exceptionally important. It's the number one payer for substance use disorder or opioid use disorder in the country. And yeah, some states cover commercial, some states cover Medicaid. We're continuing in New England. I know in Connecticut and Mass and Massachusetts and Rhode Island, we're trying to get Medicaid covered services. And with changes coming, I think it's really essential to maybe start with that. Some folks say we need to look at the scope and expand that. Some folks say get paid. We say you need to do sort of all of the above.
Well, and I think that's another section that I love about each state page is that we have specifically also created a section to call out for policymakers, because we're hoping that they are an audience that will be looking at our website to say, all right, well, here's what the existing laws are. And if you want to move this forward and help save lives and help deal with this crisis, then here's what you need to do to move that forward in your state, whether you want to pursue that through existing collaborative practice laws, which unfortunately can be less than ideal in a community setting, or if you wanted to pursue some sort of independent authority through standing orders or other means in your
or like
state.
Protocols. I mean, that's the other thing
protocols.
too. We think about vaccine protocols. There's a time in my life where I say, if you give people buprenorphine, you're immunizing them against overdose because of the way that it acts. And again, with long-acting forms, you're really protecting people for a month. It's really dramatic. Just like also for states have expanded pharmacist authority for a corresponding condition, HIV pre-exposure prophylaxis. Now we have long-acting forms there. So the other thing I'm sort of trying to advertise, and we'll probably expand on the website, not to jump ahead, but to say, if you pass policy, if you get to some of the resources to tell you what to do now that policy is passed. So we have the existing policy, suggestions to change it. People can point to this and say, oh, look, there's a state that's doing it. And I think that's the important thing, to do a state-by-state analysis. And then how do we implement it? What's the workflow? And so we presented some of that research that Michelle did, a whole other podcast probably. But we'll have all that on the website. So we're not just giving you policy, we're giving you solutions. And then once the solution is passed, hey, this is how you implement, because that's sometimes the biggest problem.
Oh, absolutely.
Which, again, could be payment, or could be, wow, we have payment and scope. How do we go forward? And it's a living document. I think the important thing is we're going to keep updating this. This was updated as of a year ago. Laws have changed. So if you're listening to this or you've been to the website and you have suggestions to change it, we're happy to do that.
Yeah, let us know. There's a button right at the bottom.
There's
that
a
says,
button at the bottom.
If we missed something, please let us know. Because laws change all the time.
We know those things. And again, that's we definitely want your state to be represented. So we talked about the maps, the states. We sort of talking about the resources. Again, we're going to highlight other 4 grantees and things. And just yesterday, I got an email from a community MOUD plan for Washington State. We're going to post all those things, we're able to do that. Now, some people, speaking of doing updates, they may say, wait a second, that's not our law. We understand that. Interpretations are there. Tell us about the methodology page that's also in the LAPA report.
Yeah, so the methodology page on our website is quite literally taken directly from the LAPA report itself that describes...
Which is also posted on the website, too.
Yes.
So you can download the whole thing.
In multiple places.
You got it.
But it describes in great detail exactly how our colleague, John Woodruff, went through the process of deciding what these, 10 questions were going to be, and then figuring out in each state, what the answers to those questions were, essentially.
With references to the law.
Yes.
So, again, he is not a pharmacist.
No.
He is a lawyer, but I think that if you go to the LAPA.org website, you'll find several other pharmacy-based, we worked with them to do a methadone project from a federal standpoint. They also, I actually helped them and knew about them. I was asked to consult on a model collaborative practice agreement for MOUD. And so that also will be linked, and their report is on their website too. So I think maybe we should round out the questions. We had independent prescribing, CPA prescribing, independent administration, CPA administration. We have lab tests, because lab testing can be part of that. Telemedicine, which is a huge thing. Pharmacists drive telemedicine, and then public and Medicaid, and then commercial payers. So I think that covers everything.
And there's one last one that's like any other laws. It's just a general catch-all.
Which has been also reviewed by another website that, again, people will listen to this and go, wow, there's a whole other website about harm reduction laws and laws related to Good Samaritan Acts. So that's pdaps.org, or pdaps.org. They also do policy analyses. So again, we see our website as a catch-all for these things. Even if your state isn't represented and you don't have a toolkit or something to post, if you go, I go to this website, we'll put it in our links page under those resources. So we'll link to all these things.
Yeah, our hope is eventually each state page will have its own links to resources that are specific to that state, but also will have resources that are just, more general for that apply in any state or across the board. Yeah,
educational resources, again, the CPA site, all those other things. So we're being very optimistic. We know that legal change takes a while. Right now, there's no federal lawmaking going on. But states do this, and we think that since states regulate pharmacy and they regulate medicine, we're seeing more and more states introducing legislation and passing legislation for standard of care, standard of practice acts, where, you practice how you practice, like nurses or doctors. I think this is a field that can, because the results are so dramatic, not just reducing death, but it's cost savings. I mean, when we did the study, patients who got their care at pharmacists, they stayed there dramatically more than in usual care. No offense to usual care, but it means that there's a gap that pharmacists can close.
It's the accessibility, really.
Yeah.
I mean, our physician colleagues often have wait lists that are very long.
Absolutely.
Because we do have, a lack of primary care providers in the country, especially in Rhode Island.
Yeah.
And so, the wait lists are long, and I think it's just a really critical thing to recognize that when somebody is ready to get help, that is such an important window of opportunity.
Absolutely.
And if there are barriers thrown up in their way when they're saying, hey, you know what, I really need help, and then all they encounter are, sorry, you got to wait 6 months to be seen.
You could die tonight.
Yeah,
I mean, that's the thing.
You could die tonight. You could die the next day. We could miss that window of opportunity. And whereas, there was a really powerful example you told me about the Rhode Island pilot where someone came into a community pharmacy and said, I would like help, I would like buprenorphine, and they left in an hour with a script. Yeah. That's incredible.
Not just the script, with the drug. Yeah.
Right.
Yeah.
With the drug in their hand.
They took it. They know what withdrawal is, and they waited for withdrawal. And that's the other thing, too, is that sometimes we think, paternalistic health care is good. There are probably instances where it is. But here, like, these folks, we always trust the patient. We meet the patient where they're at, and they're in the communities. The pharmacy is there. We don't need to train a whole new workforce. I'm not going to deny pharmacists will need training. There's required training to get DE licenses, and I encourage states to expand their authority to allow DE license, because there's lots of other controlled substances that we know how to dispense.
Right.
We know how to monitor. Prescribing it is a hurdle federally and in states, but we can ask states to, and that goes into those policymaker recommendations to say, okay, maybe one step is to get DEA, or maybe just getting the ability to prescribe buprenorphine because it's so different as an opioid and because of its indication.
Right.
Okay. So we've got some barriers. We know that things take time. Again, the website is taking time. So we're going to keep expanding that and keep adding things. So please go to the website and expand it. And our emails are easily found. What should people do next, Michelle?
Well, I think, certainly check out the website, see what the laws are in your state. If your state is one of the ones that is currently empowering pharmacists to provide these services, then I would advocate to try to add that to your services in the community pharmacy.
And maybe people don't know they can do it, right?
Yeah, you might not know that you're in a state where this is possible, and potentially you could get, reimbursed for it, right? So even if they're not, you could get coverage potentially through insurance for administering long-acting injections.
Yeah, maybe you partner with someone and you go, wow, I may be uncomfortable prescribing or I need more training, but if you're administering other long-acting medications and you allow controlled substances, maybe you don't need a DEA for that and you can do it. Or maybe you can do a CPA with an opioid treatment program and administer. I mean,
that would be a great place to start.
Community pharmacies are doing it. There's several telehealth providers that I know in California and Idaho and Pennsylvania. So a diverse array of states where in community pharmacies, the pharmacist is administering buprenorphine. Of course, there's clinics and hospital systems where that's happening too. So our website's meant to unlock you're not the first person.
Right.
Let's gather folks. Let's exchange best practices. Let's put it on the site, and then you can tell your policymaker you're not the first either. Right. There's always a fear. It's an opioid.
Of course.
It's a controlled substance. We're aware of all those things. But I think that there's those opportunities. So now let's say you're a state that has a ban on everything.
Oof.
Yeah.
Unfortunately, there are way too many of those.
Yeah. There's a lot of check out the hexes, everybody. Yeah.
In that case, probably starting with the advocacy to expand the scope in your state would be, the place to start. And for that, the policymaker section on your state spells out exactly what needs to happen in order to make it possible. And we've split that up into either, collaborative practice, which, basically every state already has existing collaborative practice laws. So that's probably an easier lift in terms of driving policy change if your state currently bans everything.
Yeah.
And
maybe not ban, maybe doesn't currently allow
support.
No offense against the pharmacist, this may not have been your chief advocacy role.
For sure.
I know a lot of efforts have been shifted towards other public health priorities. We all understand that, so everyone has limited time.
Yeah.
But yeah, I think that's a great idea, and we want to be very clear. We don't have a 10-page guide on how to advocate in each state and specifically what you need to do. Although that's not a bad idea. More work, Michelle. We'll do that.
Add it to the list.
Add it to the list. But I think the idea is to say baby steps that really start with awareness. Hey, we can close this gap. Or hey, did you know this gap was here? Hey, this is cost effective. I always say again, if pharmacists are already doing services. There's several states that I can think of where they're doing PrEP, they're doing contraceptive care, they're doing smoking cessation, which is another nicotine use disorder. You're already giving people more access to those public health issues that a lot of folks with opioid use disorder have. So now maybe that's the key thing, is to get people access to those services is treating this disease and so on and so forth.
Yes, adding that screening for opioid use disorder to what you're already doing.
Or maybe even referrals. I mean, the positive to CPAs is pharmacists like their patients to be connected to doctors.
Absolutely.
This is the primary care problem. We passed a law in Rhode Island. We have the ability for pharmacists and patients to agree to extend a script, non-controlled, for 100 days.
Yeah,
which
is great.
Which is great because...
But necessary because we have an absolute crisis of primary care providers in the state.
Yeah, I was listening to a podcast today, because this is what podcasters do. We listen to other podcasts. On the way to campus today, and they were saying... just thousands, we're like 1 million doctors behind compared to other countries.
The wait list just to get into care is at least 6 months.
And to be clear,
no matter where you go, if you can find one that's accepting new patients.
Right. So, we're long. Actually modeling what has been pushed by federal agencies, again, that I've helped consult with, to say, people may be listening to this going, who cares about primary care? Okay, we hear pharmacists need to close this gap. But you're talking about addiction. Addiction is primary care.
Right.
It's a chronic, relapsing, remitting disease.
Absolutely. And where are they getting their referrals to a specialist from? From their primary care provider.
If they even need it.
Right.
Right? Does every person with diabetes get referred to an endocrinologist?
No.
Does every person with hypertension get referred to a cardiologist?
Definitely not.
So there's lots of folks in primary care, however it's defined, who are treating common diseases with drugs that are far more dangerous.
Absolutely.
Like insulin.
Insulin
like
is
metformin.
terrifying.
Right. So I think, again, we don't want to, I don't want to go into this comparing like you're already doing a thing. We're just trying to lower those barriers, lower the threshold.
Lower the barriers.
Lower the threshold to say you're already doing these things. It's estimated that 45% of people who are being seen in primary care have some indication of substance use disorder on a spectrum of unhealthy use to actually diagnosis. We totally understand you can't, I think they said it would take 12 hours to screen every patient for every single disease. But this is such a critical part of their life, their community, their family, so stigmatized that when you start treating folks and you see, what I hear from my colleagues is if you see someone get the med and they become a different person and get a, if they don't have a job, they get a job. If they've had problems with taking care of their kids, they take care of their kids. It's so rewarding when you ask these providers to say, wow, you got into that. And our pharmacist said this in our pilot. Wow, I love helping people. I love getting them to the point where they can actually deal with some of the social drivers of health. By pharmacy access is one of those things to relieve it. So we're going to cure everything, Michelle. We've done it. Just one website had to cure it all, right? One website to cure them all.
I wish it were that easy.
But so thanks everybody for listening or watching on our deep dive into PharmacyBridge. Pharmacists are essential access points for medications for opioid use disorder, but state laws, regulations, and practice models have to evolve to maximize that potential. PharmacyBridge is a tool to understand and act on those barriers and provide opportunities. Visit PharmacyBridge.org today. If you like this episode, share it with your peers and colleagues in pharmacy, academia, or policy, or all three. We'll be back with more descriptions of the website, I'm sure, in the future. Thanks, Michelle.
Thank you so much, Jeff.
Thanks for listening to The Regimen and Drug Topics.